Well, why don't we go right into the first paper of the day then?
Good morning, everyone. I also wanted to share a thank you to Harrison for inviting me here and for really everyone for just the amazing conversation yesterday and what I know will continue this morning. I also would be remiss if I didn't thank my resident, Mike Cleary. He's a University of Michigan fourth-year emergency medicine resident who worked with me on this paper and unfortunately couldn't make it today, but he really is awesome. He's also working with me in the Detroit Health Department over the next year, so working with him, he's awesome. So I really think when I was looking at my, notes for what I wanted to say today, I really think that a lot of what we talked about yesterday was covered in some of my papers. So I believe in brevity, as I know a lot of you all do as well. But I want to pull out some of the most important points. And really, again, the paper was about thinking about social emergency medicine, incorporating the basics, really, of public health into what we all do as physicians. The first point really is that we have to change, again, to the point about let's just be a good doctor. We have to change how we practice medicine and think just beyond just our prescription pads when we talk about how to best serve our patients' needs. And one thing, again, I don't want to rehash the conversation yesterday, but I think one important point is when we talk about the value of the emergency department. I know everyone talks about unnecessary care, which we talked about yesterday, but when you think about how much an emergency department visit costs, it's about 1/10 of the cost of an inpatient visit. And if folks are already coming through our doors, right, the value to our hospital CEOs, to our community members, to policymakers is, hey, sure, we're more expensive than a primary care visit, but we're actually a lot less expensive than a hospital admission. So why don't we frame it when we talk about why it's important that we do things in the emergency department, we can frame it that way. And again, really shifting the norms of emergency medicine from seat and street to what can we do when a patient's in front of us. The second point I think we really did a good job of actually discussing yesterday from Dr. James' article and all the great work that my shero, Dr. James and Ted Corbin are doing in violence prevention efforts across the country, but really using this public health model where you're looking at primary, secondary, and tertiary prevention, which in public health is kind of, that's what we talk about all the time, but primary prevention being before anyone even gets the disease in the first place. I'm not even talking about screening. I'm not even talking about homelessness. I'm talking about way upstream. And when we already know they could be at risk potentially for having these things, how can we get upstream as physicians and really try to address some of those social determinants before they have an impact on the health? The third point of my article, I think, which is what I hope we can talk a little bit more about today, is about leadership and education. We're uniquely suited, whether it's because we naturally had an affinity for the specialty or because it's just how we're trained. But we are folks who, if you think about running a code, we're folks who don't have all the information. We know how to step in, take charge to the big picture, but also get into the nitty-gritty details, right? We are actually the ones who are best trained outside of emergency medicine, right? Those skill sets, and a lot of the reasons why I think I've been quite frankly, asked to go into some of the roles that I've been in is because I just have this kind of natural ability to see the forest and the trees and do both at the same time and be able to delegate well. So I think emergency physicians and what we have to tell our students and residents is, you know what, you have a great skill set. We actually can, and I think should be talking to not just other specialties, but folks who actually are not physicians, have no interest in being a physician, but they're working on some of these problems already. We can be joining, working with others, but not saying we don't, but working outside of our own specialty organizations. Again, for at least the past 15 years, I was walking over this morning and someone was asking me, that was an interesting shift you made to public health. I'm like, well, if you think about it, I've probably been doing that work for about 20 years. So it was just a natural next step for me in my career because I was always doing the medical thing, but also with my colleagues who maybe had PhDs or MPHs or sociologists, whatever they may be. But I think it's really important that we get outside of just medicine and work with our colleagues in other areas. I also think it's really, really important, and my colleague, Dr. Meisel, who I really liked his commentary, but to talk about what tools we can give our up-and-coming emergency physicians. I was very lucky, actually did a health policy fellowship at George Washington University after residency. So I got my MPH after residency for many reasons, one of which was I wasn't sure if I got my MPH before I finished my medical training if I would go back, because I thought I would love it so much. But I think whether it's an official fellowship or even just incorporating basics about health policy and the healthcare system into our general medical education. We have to be able to speak the language if we're going to be able to advocate effectively for our patients. How many physicians have no idea how their patients even paying for their care, have no idea the difference between Medicaid or Medicare, or what, the real robustness of the Affordable Care Act is outside of just getting everybody Medicaid. So I think it's really important, and I've been lucky to be able to work for chairs of departments, whether it's currently at Henry Ford Hospital, when I was at George Washington University, and at the University of Maryland, where they really saw the value of this kind of health policy and social medicine curricula being incorporated into the education of both medical students and the residents. But I think we really have to own that and really make it part of, I forgot who said it yesterday, but I think it was in New Orleans perhaps, but that kind of community education residency, just being part of the education, not something extra. Those people who are just idealists and want to save the world, those people over there do it, but no, it's just part of what we do. So that was my last point, is really hoping we can focus on giving our up-and-coming physicians and emergency physicians those tools and training opportunities.
Good morning, I'm Chris Barsati. There were a couple of themes that Joni mentioned in her article that really resonated with me. And the first is that we cannot let society look past the patients in our home. But my experience is that society, no one's going to help us unless we tell them first what we need. And we provide a critical service to society, and everybody depends on this. And this is an opportunity to leverage, not just individuals, but there are many social agencies, law enforcement, social workers that depend on us to discharge their responsibilities for public health and safety. Moreover, there is a constant pressure to extend our accountability and solve even more complex problems. And sometimes it can feel like we're at the bottom of the funnel and all of society's problems kind of flow down to us and we have to just figure it out. And examples are the homeless drunk, they drop him off, sure, we'll just sit on him and we'll babysit him and he'll sober up. That the mental health patient that's being boarded for 2 weeks, and we can take care of that, we'll just keep feeding him and counseling for 2 weeks because you guys won't fund mental health services and there are no beds. Or, for example, the patient who does something dangerous with a gun, there's a neighborhood, but there's no law to disarm or prosecute him. Sure, we'll take that patient on welfare check and we'll figure out risk, we'll be accountable for the outcomes. I had the craziest case a few years ago where a prisoner was discharged from jail, had served his term, chronic mental health conditions and medical conditions, and a nursing home wouldn't take him. So they discharged him to the emergency department for us to figure out the problem. And that's just obvious abuse, but that shows you how society perceives us. We solve impossible problems. And it's easy for docs to feel like the victim in this dynamic. And it contributes to our burnout. And this is one of the reasons why there's going to be resistance to docs adopting, addressing the social determinants of health. But like Joni said, if you hold up a mirror to the laws and practices that we participate in, you realize that the same laws that make us accountable can help us invert the power dynamic in these relationships. So since society depends on us, it's in their best interest to make us successful. And we see the whole arc of the problem, we see the gaps, yet identify opportunities where there can be changes. And so it's our job to inform policymakers so that they can make better decisions. And their job, they're in a role to help lift our load and make us more successful. For those of us who don't have a policy background, being an effective advocate can be difficult. And I was never engaged in policy work until 2 years ago when there was a legislative initiative going on in my state, and it was very sensible and it would solve a certain problem. And then I read about the opposition to it and their arguments why the law wasn't necessary, and I had all these cases that would demonstrate why their argument is completely false. And I thought, well, I can help. I can tell my story. And it was really hard to find out who to talk to, when and how. And it took probably 3 or 4 weeks of making calls and not getting calls back, using these standard channels that people tell you to do, call your senator, call your representative, until I found the right person, which was a lobbyist. And once I was connected and they saw the value of an emergency physician's perspective on this problem, then they utilized me like crazy. And after that, I was able to testify several times to help get this law passed. And since then, I've been able to testify on other similar laws that regard public safety, because now I have relationships. So I think that part of a core competency of any kind of curriculum for social emergency medicine is going to be training physicians on just the basic advocacy and policy, like who to access for state, for regional, interdepartmental, hospital policies, so that we know who to talk to, so it's easier for us. I don't know about federal government, that's not very helpful these days. So I think educating ourselves is important. And then lastly, and this is what Zach is going to speak to, is how we can be more effective. And I found that when I was testifying, that the narrative conveyed a lot of power. And Garen Winston once told me that data is just air cover for a good story, and that's very true. Using the power of the narrative backed up by medical evidence is very powerful, and it changes minds.
So I have the unenviable task of giving the last commentary, and I do want to bring the discussion a little bit around to, I think, a place where we started, which was starting to think. I think we maybe even somebody said yesterday that maybe it's a little premature to think about implementation or scaling up ideas that come out of this, but I think maybe now is the time. I really, it was a pleasure to be part of this. Thank you, Harrison, and to comment, Joni, on your beautiful paper. You know, one of the things that really struck me is thinking about this idea of education and leadership. And one of the first places that we, I think, need to turn when we do that, education and leadership is often about how we interface and interact with our colleagues and our peers. But there's a huge opportunity for us to start by looking at ourselves. I don't think any of us have nailed this on the head, even though we may be the converted. We are all can live in this dual space of being somebody that cares about the social determinants of health and can't or don't actually act on it at any given moment. I'm going to talk a little bit about stories and narratives in a moment, but I want to share a story. I think it's a story that we all have and know, which is that of the emergency department provider who at one moment can be fiercely egalitarian, will not expedite the care of the VIP in the waiting room with a minor complaint over the sick, poor, homeless patient who's ahead of or needs to be seen first. And at the same moment, or at the next moment, will go ahead and kind of roll their eyes or shrug their shoulders at the fact that the patient is back with the same episode of hyperglycemia. And even though that hyperglycemia is due to the fact that that patient lives in a shelter and his insulin syringes were stolen that day, right? And we not only see this in our colleagues, but I think we see it in ourselves. I certainly do. I think on any given shift, I can be both, both righteous and cynical at the same time. And how do we kind of bridge that? I don't think getting rid of emergency physicians and expunging our salty humor and the fact that we can be cynical is not going to happen and probably shouldn't happen entirely. But at the same time, we need to be able to focus ourselves in terms of thinking about opportunities to move this ball ahead. So how do we do that? How do we focus? How do we lead? And how do we educate in ways that actually are meaningful? And I think we've talked a lot about some of the ways already here, and Chris and many others have mentioned the power of narrative. That is a place where I spend a lot of my time thinking about. And I think a compelling narrative or social narrative is what I would call it. I mean, there is a literature around this idea of persuasive narratives, but persuasive social narrative is key to actually thinking about scaling and implementing, not just one, obviously many. And that goes beyond the case example, right? I mean, we talked a little bit yesterday about having a battery of cases ready to go that need to be deployed when the right opportunity comes up. But a good narrative is more than a case. It's about a person. It's got characters. It's got some conflict and resolution. It has a beginning, middle, and end. And we've all have them, and we all use them all the time. But thinking about using them in a deliberate way is important. They've been proven to be able to adjust social norms. We had some discussion yesterday about doing that. And they also have have the ability to induce empathy. Dr. Wolf mentioned that as a key part. So I think we should think about where these narratives are in terms of being able to implement, scale, disseminate, and change ourselves in terms of being more attuned to the mission of social emergency medicine. The other pieces around implementation are ones that we already, I think, discussed yesterday, at least were the ones that I put in my commentary, focused on return on investment, which I think has some challenges, but is important as part of that narrative, actually. And I think now may be an opportune moment to think about some of that piece, largely because the emergency department is often viewed as a place where expensive, inefficient care is delivered sort of at the sharp end of the curve. And if we can make an argument that that's not necessarily the case, and that certainly if we can focus on prevention, we may actually be able to move that argument a little bit. And I also have a third plank in my commentary focused on choice architecture and behavioral economics. I think we already again heard a lot about making the right thing to do, the easy thing to do, and there's lots of creative ways to do that. There are people in our community who are not necessarily going to change, and if we make the defaults that live in our environments ones that actually can help our patients, independent of the provider, then we can potentially push this ball down the path as well. So again, thank you, Joni, for talking about passion and leadership and education. I think professional norms are insanely hard to change, and if we can bring the power of narratives and making the right thing to do, easy to do, into our environments, we can really actually help all of us meet the needs of our patients where they're at. So thank you.
Comments, questions? I just would like to interject. The cost thing makes me crazy. The persistent hammering away that it's the most expensive place to provide care. First of all, your take on that is brilliant. It's never even occurred to me to look at the proportion of ED visits that have avoided hospitalization. That's, I think, be a difficult question to study, but could have an enormous impact. The other thing is we have no idea what an emergency department visit costs. Nobody studied it since 1998, as far as I know. Bob Williams estimated the marginal cost of a low acuity ED visit in 1998 at $24. We know what we charge, but we have no idea what it costs. And I actually think that, we have to stand up against that. The fact that people assign us as being the most expensive place to receive or provide care is an arbitrary, I think, assignment. And it's frustrating to me.
I would echo that comment, and I had an interesting experience that I did a review of like emergency department visit reduction programs for MACPAC, which is the equivalent of MedPAC in DC, and we went to go present our results, and we found that like there aren't a lot of programs that are effective at reducing emergency department visits. People keep coming, and the literature is pretty bad. But I will never forget like sitting around the table with like literally the MACPAC commissioners who were like, but an emergency department visit's so expensive, because I was making the argument that actually like for Medicaid, an ED visit is not all that much more expensive than a primary care visit does cost more, but Roberta made the point actually that for FQHCs, it's actually not more for Medicaid when you compare it to an ED visit in a lot of areas. And the commissioners were like, wait, what do you mean? I was like, do you not know what you reimburse? Or because in San Francisco, I work with the health plan there, and it's in the neighborhood of, $200, let's say. And none of them realized that. They all thought an ED visit was $1,200, kind of like across the board. And so there is a real misunderstanding of just even the concept of like, what is the cost? What is the charge? What is the reimbursement? And, a lot of the articles that are published in the Times, which everyone reads, they talk about charges, which just really gets my goat, because it's sort of, that the charges really apply to people that have no insurance, which is fewer and fewer people in our country. So it's not a really accurate way to look at things per se.
Well, and also hospital accounting has never caught up with what their actual time and motion costs are. They don't know. They don't know the piece costs of an ED visit any better than we do. They just assign a charge to help them balance their budget. It's completely arbitrary.
I don't think that you can necessarily argue that like it's not that the ED is cheaper than primary care. Like you can't go too far in that direction.
It's not better.
Or better or anything like that. But I think that people inflate in their minds, and the lay public feels like the ED is the most expensive place. And to your point, it kind of pales in comparison to one night in the hospital. So if we can use ourselves to prevent that one night, and I think we do a lot of the times increasingly with the kinds of workups that we can do now, then we're actually potentially saving money for the healthcare system.
There's a little bit of a cognitive dissonance.
Oh, I'm sorry. I was just making notes. Sorry.
So I'm going to be a contrarian. I agree with some of the comments about not knowing the exact cost of emergency care, but it's important not to delude ourselves. The price of an emergency department visit is, for most people, much higher than the price somewhere else. And whether it's the insurer paying them or if it's out of pocket because they don't have insurance, it is expensive. And so there are, how that gets accounted is important, and we should be speaking up in our institutions about that, because a big part of it's the facility costs, and that may be inflated to cover other overhead. But actually, if you look at the, physician, nursing resources, other resources, physical capital of being seen in the ED compared to being seen at many other places, it is more costly. So that is just a fact, and we need to accept that. It doesn't mean it's not valuable, or that, so I think that's just saying sometimes we delude ourselves into. But more importantly, in this debate, or not debate, but in this discussion, I think the important aspect is, as we think about bringing programs and actions to these populations, and taking on tasks that are not seen as currently within the workflow of emergency medicine, it's important for us to honestly, and it's a research area, to look at where there's cost effectiveness of the location of the intervention. As emergency providers, most of us think that this should be, we just naturally tend to think these things should be done in the emergency department. But hospitals are more expensive. If a nurse works for a hospital as opposed to a community health center, the cost is higher. The overhead structure is higher. And so locating these programs in other organizations may be a more cost-effective way to do them. And so I think that's something we need to be open to.
Yeah, and just to respond, I agree, and I think what I'm talking about mostly is probably applies mostly to individuals that have Medicaid, which it seems to be, what a lot of people talk about, kind of in terms of, you know, avoidable ED visits or whatever you call it. But yes, I mean, yeah.
The only thing I would say about that is that, you know, most emergency medicine organizations argue, I think correctly, that the reimbursement for Medicaid does not pay for the actual costs of care. And we're actively, you know, pushing our Medicaid organizations to increase that reimbursement. So I don't think we can have it both ways.
Yeah.
Roberta, and then Jay, and then I'd like to say something.
Yeah, I was just going to make the point that it depends on the stakeholder, right? What lens are you looking from? Like, there are studies done with patients and the opportunity cost to them, and what does that translate into, not just in dollars, but in their time in using primary care versus emergency department services for low acuity conditions. There are coming and going and at random, so not chronic disease related. And we know that for most vulnerable patients, that opportunity cost is much higher. So from a patient's perspective, it's rational for you to utilize the emergency departments. From a stakeholder perspective, you're right, it depends on the insurer. And then from the facility, it's a completely different set of eyes. So I agree with you on the entire concept that if we were to normalize it, it would be more expensive. But at the same time, we're not normalized. We're not normalized by the patients. We're not normalized by the payers, and we're not normalized by the hospitals.
Yeah, you need a social perspective in order to really figure it out. You need everybody's costs, yeah.
Or who are you trying to target?
Oh, we have Jay and me and Chris and Johnny. Oh, and Dennis. And go, Jay.
Okay, all right. So a couple of things. Number one, the cost associated to the patient in dollars out of pocket does not take into account the cost associated to the patient when the patient missed several days of work due to the fact that in the emergency department we can get everything done in a couple hours now. So in that sense, I'll comment off what Jay Scher just said, which is that the key word in what he said from my perspective is cost effectiveness. Is where can these interventions, number one, if we show that these interventions have an outcome that's positive both for the patient and in terms of cost, where's the best place for them to be done, but how can they be most cost effectively done? I think in a time when the major driver of healthcare is cost, one of the things that the board has been focused on, the ACEP board has been focused on, is how do we show the value of emergency medicine in saving cost? And so I was looking over the questions that people have posed, and some of them have to do with how do we show outcomes, positive outcomes from the social determinants of healthcare being addressed in the emergency department. How can we show positive outcomes both in terms of cost and in terms of outcomes for the patients? ACEP has a grant which we're getting, and I don't know, Cynthia, if you want to talk about that at all, but ACEP has a grant which we're getting from Emergency Medicine Foundation to define the value of emergency medicine, because we are also tired of hearing that we're the most expensive place. And all that people are looking at when they do that is the dollars, quote unquote, the dollars out of pocket. They're not looking at the value that people receive for that. And anytime you really should look at cost, you should look at the value received for the dollars spent, not just the dollars spent. So ACEP as an organization is going to be focusing on that.
Great. I think I'm next in line. I just wanted to say that, Jay, I take your point about needing to demonstrate that our interventions that we propose are best done in the emergency department or would be best done in another setting. I think one of the sort of organizing principles that I think about in terms of conceptualizing social emergency medicine is just the fact that people have voted with their feet, and that we have access to populations. We can try through behavioral economics or whatever else to redirect them, but we've tried a lot. And people like to get their care in the emergency department. And so while we're working on getting them to go elsewhere, if that's what we decide as a society that we want to do, we still have them in our ED. And being able to deliver services, interventions things to make their lives better in the ED from a social standpoint, I think we ought to do it while we're figuring out the other stuff. If we want to try to redesign the healthcare system to get people not to vote with their feet. But right now they're picking us, and at a massive rate, and they're here, and I think we just should deal with that. That's
I was going to say, I wasn't arguing to redirect patients, but as we think about adding new interventions, there are certain interventions for which the ED time is critical, and it may be a moment of learning. And there are other interventions where having a community health worker find them in their community may be as effective or more effective and less costly.
Yeah, no, absolutely, I agree. But the ED may be the only place to get that started. Let's see, I have Chris, Joni, Dennis, Jerry, and Ed.
I just wanted to say that in thinking about ED utilization, we have to consider also the ascendancy of urgent care centers. I don't know about where you are, but they're populating centers all over the place. They're like gas stations. They compete against each other on corners, literally. And so there is this cultural push to promote the idea of on-demand care. And when urgent care centers are closed, then it's the ER. And moreover, I don't know how the situations are in your employment contracts, but for us working in the main department, the urgent care center that's on the other side of town, and where patients are being seen by PA, we are responsible medical legally for the care of those patients. So our accountability is extended to the urgent care centers.
Joni?
And my comment was really echoing yours, Harrison, about the, I wanted to be clear, when we talk about these interventions, I don't think anyone's saying, let's put up a shingle at the ER and you can give me your homeless, your poor, whatever, just come and see us. I think it's more about meeting people where they are. I mean, I'll say in the health department, we actually are doing exactly what you just said. We're developing with the University of Michigan a community health worker program embedded in the community with people who are from the community and partnering in that way. But again, sometimes you just aren't seeing people. At one point is when they're in the ER. So it's really about us just owning that and seeing what we can do, which can potentially stop them from ever coming back again if they don't really need to see us, or they can get connected to primary care or whatever it may be. But I think it's just that point about just meet people where they are, and they are coming to us.
Dennis?
I think echoing that, but also sort of acknowledging Dr. Scher's point of, even though we're meeting people where they are, where does that intervention take place? Is it in the moment, or is it over time and not necessarily in the ED? And I think just a second point, repeating what I said yesterday in terms of not just making it the easiest thing to do the right thing, but also how do we set the policies, and can ACEP help with this in terms of incentivizing the correct behavior financially?
Jerry?
Yeah, it helps me to think about this if I try to distinguish between what I might imagine the best circumstances in an ideal world versus what is the best way to handle life in the real world in which we live. I could easily imagine a different healthcare system with a much more stronger and more available primary care system, which I think would be a huge advance for us, and with a much greater community health service system, that would be a huge advance, where many of the things that I think are critically important to what we do today should not be in the emergency department. They would be better done elsewhere. So I think it's the wrong thing to argue it's best in the ED. But I also think it's very short-sighted when people say that's too expensive, it's the wrong place, the ED, when there is no alternative today. And that is the reality in American medicine. So I don't want us to get caught arguing that the ED is not so expensive, or the ED is the best place to do all these things. I'm not sure I'd want to be an emergency physician if I lived in one of those communities, because I don't want to just be taking care of codes and gunshot wounds. I want to be doing all the things that we think are important. But I don't, I think we're trapped if we start arguing that the ED is the best place for these things. It's the best place for these things given the alternatives. If patients had the opportunity
to not take 4 days off work, to, I hate the word on-demand care. It sounds as though the patient is demanding and insisting on something. It's meeting patients' needs. If we met patients' needs better in all the ways we know are better in a healthcare system, we would have, some of this would be unburdened from an emergency department, would look very different, but it isn't. And so I think that's the argument we want to make is that this is within the constraints of reality in American medicine today. This is why it's not only important and valuable, but also appropriate and not costly to do things in the emergency department. That isn't to say that you couldn't imagine a world where that would be different. And I think we should insist on keeping those two separate. We're arguing for what's best now in reality.
Like Churchill on democracy.
I want to thank everybody for setting my brain on fire all last 2 nights, so that it's hard to sleep when you think about all these issues. I wanted to share with folks something that comes out of these papers. One was the treat and street culture that we're all trying to change, and I think it can be changed, but not as much as we thought we could. So over the last 23 years, I've worked with a program called Project Assert, which brought community people into the emergency department to go room to room and screen people for their health and safety needs, and focus on it and linking people to primary care, substance abuse treatment, and preventative services. And we've survived, and we've been picked up after the first 3 years by the hospital. It was a benefit, and they pay the salaries. This was great. And it's ED based. And now under this, preparing for this new phase of our ACO, which Dr. James began to describe, they want return on investment. They want to see how we're doing. So we actually were funded to develop an ambulatory model for our program. So instead of going to the bedside and spending considerable time when at the same time we have 4 to 8% left without being seen rate, we're able now under an ambulatory build with an electronic medical record to bring people to our office outside, adjacent to the emergency department, and begin to do assessments of need and negotiating a treatment plan and placement and opportunities for people to address whether it's addiction or their homelessness or whatever. So that's sort of adapting to the real situation. And I just got the email today about, we have a few days to get in our return on investment database so that we can get some money from the ACO, they call it disproportional share funds, to build more infrastructure and to cover us late in the evenings and days. Adjacent to this program is a medication addiction treatment clinic. So because the opiate crisis has led to this, so that we know that the emergency department co-pays up to $100, so we decided it has to be ambulatory, and that any physician that would want to do something about it, and I'm an ex-wave physician, would have to have some backup. So we have a nurse-managed program where we have doctors every day of the week to address this. So I think there are different models that we have to think about to do the same right thing and adapt to the economic realities of our situation. So I just wanted to share that. The last point that comes over this is we've been struggling to, since language makes a difference, and this is a separate point, but I thought I should make it now since, so we've been struggling with ourselves not to look at our patients in a derogatory way. I think everybody here has, great social compassion and impact that we're not aware. Sometimes when we use the word addict, drunk, alcoholic, how that as a stigma could disempower people, make them feel that they're less than or marginalized. So we're really struggling with all of us to change our language from junkie and shooter, and to show the respect in our language. Thank you.
Steve.
I too, it's been just a great 1.5 days. This has been fantastic. I do want to make one comment with Joni's paper and her call for developing leadership. It's absolutely critical. And the way I've liked to frame leadership development is that we start out as emergency physicians, fierce advocates at the bedside. We're pretty damn good at the bedside, being advocates and leaders for our patients. And the history of emergency medicine is, I find it fascinating, at least in our area in Milwaukee, we actually started where patients are, on the curbside, in a car. in their home and develop EMS. It was started by the National Academy of Sciences 1966 document that outlined the modern epidemic of modern society, injury, called for development of EMS. That's where patients are, and we start there and then bring them to the emergency department and start organizing emergency departments because they were chaotic, and now we have emergency physicians and emergency departments. So this comments about where patients are is really interesting because the paper did not discuss much about our partnership with EMS and about how perhaps I lead a discussion in the bedside with a patient who has some issues about follow-up and home issues, and then I can make a referral to the community EMS to follow up. So I'm leading that effort at the bedside with a partnership with community EMS. So we don't have to do everything, but we can initiate things that are critical to get to the point where we're not going to do everything in the ED. We actually have a follow-up process that gets us to where patients literally are. So I view leadership at the bedside, at the curbside, EMS, poison centers literally are reaching into people's homes. Opioid overdoses now, EMS is an integral part of this. To the table side, Thea James is a leader at the table side at committees and healthcare systems, making a difference in that leadership position. Joni's at public health, making leadership decisions that affect populations beyond the bedside of an individual patient. And then Chris has been talking about the court side, testifying, going to the legislature. So the tiers of leadership, and Joni, you mentioned this yesterday as well. These are, not everybody does all four. Maybe one focuses on the fourth, but we all start in the same place at the bedside. And that's our strength, to leverage our leadership to do things differently. And I think that's what I got out of this paper and out of this discussion, is that importance of recognizing that we have some residents who are going, you know what, you're going to be really good at the table side executive leadership skill set that makes a difference in healthcare systems. Others are you're going to be great in a community hospital, doing great. So those are my comments. My question to those maybe more familiar with this is the interesting boom of micro hospitals and freestanding EDs. Texas, it's my understanding, it's happening everywhere, where these corporations are plopping down micro hospitals where it's really functioning as an ED. Where's the social determinant elements of that business model that's going on in various communities? It's happening in Milwaukee. There's a corporation, Tandem, that's what they do. There's other corporations doing it. So I look to our ACEP colleagues about that, and where does social emergency medicine fit in with Tandem's bottom line for taking care of patients in an emergency department setting? Pardon? Right. It's just like a private school. It's taking that entity. Where are the social determinants of that?
That away once allows people who can pay to have more easily accessible, less costly, more convenient care. Where do the tax dollars go for everybody else? So public schools suffer enormously when private schools are. And so that's the model they're using. We're going to make, we're going to provide cost-effective care to the haves, and then we won't have to worry about everybody else.
It was a rhetorical question, Jerry. Yes.
I know. The logic of it.
It's interesting. In Milwaukee, we have we've got some really notable issues that we are pretty proud of, but not so proud of is that we are the site of the largest public hospital closure in the history of the United States.
One of the comments, and it's been a debate in ACEP since you asked, it's been a debate in ACEP because we have a very strong freestanding emergency department section now, and members of the ACEP board who are involved with freestanding emergency departments. And in Texas and in Colorado, which are probably two of the states where FSCDs have been most active, They have been placed, by and large, not always, but have been placed in communities where the folks are well-to-do, and insurance is private insurance, and they can ask for a payment up front. There are some places, like in our experience in New Orleans, where the health system that I was associated with partnered with Adeptus, which is a company that is very involved with freestanding emergency departments, to put 4 freestanding emergency departments in New Orleans. They opened one. They built 2 others. They're not opening the other 2. They're not opening the 4th, which was originally planned, because what they found was, in the model in New Orleans, where you have high Medicaid rate, it's not cost effective, in quotes.
Not profitable.
Yeah, I'm sorry, not profitable, put it that way. It's not profitable, I apologize. It's not profitable because they have to see 50 patients a day, whereas in the freestandings in the well-to-do communities where they've been placed, they can see 6 to 8 patients a day and make money. And one of those of us that have not been involved with freestanding emergency departments, one of our big issues with supporting them, with ACEP supporting them, was the issue that what's going to happen to our general acute care emergency departments when those patients who can pay are diverted, number one. Number two, what's going to happen in terms of staffing with emergency physicians and with emergency nurses? And we know there exists a workforce shortage. What's going to happen to our general acute care places, which we all know, and our safety net hospitals, which we all know are very much more difficult places to work than a well-to-do freestanding emergency department in a nice community.
So we have Patrina, then Maria, then Stephen.
Hi, Patrina Crane from Highland Hospital. If I could just briefly speak to some of the issues about the freestanding ERs. I think that it goes back to the importance of diversity and inclusion and coming up with trainees who have like a good insight on these issues, because there's actually like a famous freestanding ER in Houston, Texas, Lifesavers ER, that's actually started by an African-American female physician. She started this ER not in a community that is a rich community where they have like a lot of private insurance. It's actually like a more like middle income community, and actually does a lot of interventions to help better that community with social emergency medicine things. She has issues on homelessness. She does a lot of community education on preventing violence, like gang violence in that community. So it is like an option that having a trainee that has that mindset, who, if they do go into that sort of business, can actually still make a change. That's good.
Maria, and then Stephen.
This is slightly off topic from what we're talking about now with freestanding emergency departments. So I wanted to just go back and think a little bit more about this idea of lived experience that some of the papers brought up, because I think that's really important for trainees and others to, and I think probably a lot of us have, there's lived experience, and then there's kind of, I guess, experience that you choose to put yourself in to kind of gain perspective. But I think that could be really important. And maybe one way that we think about sort of the educational component of this is giving, if it's residents or medical students or other curricular things, we develop opportunities to do some of the things that people here have done, but make it more a regular part of curriculum. Like when I did my MPH, I actually completely forgot about this, even though it was a year of my life, until I was looking at your paper for some reason. But I lived in a low-income housing building because they said I could live there rent-free and kind of serve as like the doctor, even though I wasn't a doctor yet. And it was in Portland. And it made a huge impact on me, because I didn't see any people of color in Portland where I was in medical school. And I was like, this is so strange. Like, this is just everyone, literally everyone here is white. Sort of bizarre. And then I moved into the low-income housing building, which was just in a different neighborhood called Northeast. And I realized that the city was actually pretty segregated. And living in that building and living there where I wouldn't have lived otherwise made a difference for me in like my perspective on things. And I think if we can give more people opportunities, or offer more opportunities, or require more opportunities like that for people, it can just open people's eyes to what's actually going on in a lot of cities that we may not otherwise realize.
Declaration, I have no conflict of interest here because I don't own or run a freestanding ED, but I'd like to speak to the point of reframing the view we have on freestanding EDs. Jay said we have to find alternatives to the expensive opportunity that we have in our tertiary referral in our main hospitals, and maybe freestanding emergency departments could be our friends as opposed to our foes. If instead of planting them only in affluent communities, if we actually, their paradigm is to move out of the institutions, out into the communities. If you look at providers that work there, they'll all tell you their burnout rate is less, they're happier working there. And now maybe it's just the clients that they're dealing with and they don't get the steady in-stream of drunks at 2 a.m. by ambulances. But if we're trying to move out social resources and social determinants, that's actually a group we should probably be trying to engage in, trying to increase what opportunities they offer to their communities and move out from there. So I just try to tell you, I don't necessarily think that the freestandings have to be our enemies. They ought to be some way that we learn how to incorporate them. And it's exactly what you said, is move them into the right communities and get them to help us in this battle.
I expect that there will be a couple comments reflecting back on that, but first,
I think we're framing this the wrong way. This is not about good doctors who are working in emergency departments and bad doctors who are working in freestanding emergency departments. The gorilla in the room that we're all avoiding is, how is healthcare paid for? Is healthcare a business or is healthcare a right? Do we work because, do we work where you don't get paid fee for service, where how many patients you see isn't dependent upon the insurance status of the patients? So in some sense, if we as a group that's interested in social emergency medicine do not address the issue of universal health care, we're failing in a big way. There's nothing, maybe in an ideal world where we weren't paying for healthcare the way we do, there should be freestanding departments in all sorts of neighborhoods. But they don't, you can't just say, let's take them to poor neighborhoods. They don't exist in poor neighborhoods for a reason. The reason is because of our healthcare system and the way we pay for it. I don't want to overemphasize just universal care access, because I think that's only part of the problem. But it's an important part of the problem. And if we just completely ignore it and pretend it doesn't exist, all of these things will come up where we're arguing about freestanding emergency departments without getting to the root cause of why they do not solve the problems that they might otherwise do.
So we have, I'm sorry, I had Teresa, then Eric, then Lou, and did you want to speak also?
No, I think we're slightly off topic.
We are, and I'm gonna let this, these next three comments go, and then I think we're gonna redirect back to outward facing. But
I was actually going to redirect back to the issue on advocacy and how we as physicians can really encourage advocacy. And so I had just 2 points to make. One is that back to sort of the discussion of the bedside versus table side, and then also our discussion yesterday on big P versus little p and opportunities there. I've worked with CMS before when they were operationalizing the national exchange, and it was an incredibly hectic time, as you can probably imagine. And I think there's often a missed opportunity there where we as physicians have a very valuable insight, because I think a lot of times we wear white coats, go to Capitol Hill, and focus a lot on the big P. And there's a lot of little p issues that we have that have a profound effect on many communities that we're engaged in, and that we sort of just overlook and miss. And so, for instance, with the Affordable Care Act, for instance, we have, once the bill was passed, there's all this implementation side of things, just as we have to focus on implementation, so do the policymakers. And so a lot of the operational side of things are still chugging away, and there's a lot of role for us as physicians to actually insert ourselves in that area of conversation. So for instance, in LA, the Triple H measure was passed, which uses a lot of the taxpayers' money to provide housing for the homeless, at least it's sort of the idea. But now there's so much implementation discussion, and part of that Triple H measure also includes access for mental illness and mental health. And that's, for instance, an area where they're trying to furiously figure out what exactly it means on the ground, what it actually looks like from day to day. That's a very valuable perspective we can insert ourselves and offer, and that's an easier way because many policymakers do look to us as experts. So that was just one thought. And the other thought is, since I have the very rare opportunity to address so many faculty and attendings, as a resident at UCLA and having been at other institutions before, I just wanted to also bring up the idea of looking at we look at like local communities and then we talk about national things. So what about with our own institutions, how we can really perpetuate our own, an environment locally to ourselves within our own EDs and within our own residencies. Things like making sure that there is a social emergency medicine committee and things that, making yourselves available for mentorship. I've been at other institutions, luckily not at UCLA, where it's been very hard, for instance, as a medical student to find the leadership from an administrative perspective in medical school, to find any support for involvement in Black Lives Matter or involvement in any of these very important, timely issues that medical students and residents are very acutely aware of. But it's hard enough to figure out anatomy and figure out residency and figure out emergency medicine. It's another hurdle to have to fight your administration and fight, your institution to have that space and have that community of support that you really need to help perpetuate these ideas. And so I just really strongly urge to also look within your institutions of how to find those moments of mentorship and project development. Thanks.
Thank you. Eric, and then Luke.
This is, I think, on topic, but I wanted to echo some of the things Dr. Raven said and just now as well. And I hate to talk about the Indian Health Service things, I keep bringing it up, but in terms of thinking about opportunities and ways that we can integrate education and social emergency medicine into curriculums in medical schools and in residencies, and there's just like an obvious opportunity there in the Indian Health Service. So there's 13% of emergency physicians working for IHS EDs are board certified or board eligible in emergency medicine. And so I think there's a clear opportunity and actually I think an obligation by our specialty to help support those areas. One way to do that is to increase partnerships between academic institutions and IHS facilities from medical student levels and residency levels and at a fellowship level too, probably. And so I just wanted to sort of put a plug in and echo some of those thoughts.
So my comment was a little bit of a criticism of a couple of comments I just heard. One is that we heard a comment about a drunk coming at 2 o'clock in the morning, and also about the great pleasures of being in a very sophisticated, high quality healthcare system where you could get things done very easily. So I've spent my whole career in public hospitals where the greatest pleasure for me is the people I get to see, and really seeing the people who no one else wants to see. And it's got all sorts of names for them. And in many ways, that experience, listening to what we've said, makes you think about the debate we're having. And to me, it's the nomenclature, as well as seeing that we're not going to make any progress by creating something new that's called social emergency medicine. Emergency medicine is about going to the bedside with every human being who comes there under every circumstance at all times. And so there are plenty of problems that you might find offensive someplace. But in the emergency department, everyone is accepted for that which he or she is. And that's our responsibility under whatever circumstances. So if the place doesn't work well at Bellevue or Charity or someplace else, it's our fault because we didn't make the government give us more and to do better for the job. It's not the people's fault who come there or the inefficiencies. And maybe learning to be a doctor so that maybe one of my goals is to make sure that every doctor that I train is capable of working at Bellevue or a fancy tertiary care hospital, or being able to be dropped in the midst of Ghana and do something constructive, or in an Indian experience, or any place in the world. So it's about what we do, and if it's really not totally incorporated into the things that we believe, this isn't going to work. And we've got to find a way to recognize that we're not all that certain about exactly what we're doing and creating something special, because if every doctor doesn't go with all these principles to the bedside every single time he or she does it, we're not going to do emergency medicine. And incidentally, we're not going to be socially responsible. We're not going to do social emergency medicine.
Allowing for human failing, of course.
Well, I think we're humans.
We try to do it at every encounter, but we may not achieve it.
But we're humans, so we do things that humans do. But if we don't set the principles as though the things we're describing are done routinely, then we're not going to accomplish much. And so we should be focusing probably on the principles of the research we're going to do. In other words, people do ultrasonography. And so for some time, I've wondered why it should be, how can you have a one-year fellowship? So we build it into the training program and it becomes part of the process. So you don't need that. But the people who do creative work should be doing ultrasonographic research, maybe how to better teach it, how to do a host of things. You could get all sorts of things, but you don't need a defined specialty in everything. If our principles don't incorporate everything we've talked about on our daily activities, we don't have emergency medicine, because we're all going to be doing things. I don't think I would have any pleasure working in an urgent care center, because I don't get to meet the people who are at greatest need. With the people who need us is a great pleasure. That's why I go to work. Not to see the people who someone else can do. If I worked at a private institution, I feel someone else could do the job if I didn't go to work, because they're going to make more money by going to work or something like that. So going to work at Bellevue or going to work in the South Bronx, you know, maybe you don't do as well. And you do get a lot. You understand living in the right free hospice that Maria lived in, or by doing something that you've got to find out what's about the world. There's no better open air experience than working in a public hospital under deprivation because there's no air conditioning or because the thing doesn't get where it's supposed to or it doesn't get done. Everybody gets a bad shit, but you better learn as a doctor to change the world around you. Otherwise, you're just lazy. And so you've got to do it day in and day out, and that's medicine. That's the way I learned to do medicine, because that's the way it had to be done for the people who need it most, not for the people who need it least, who can get it anywhere. Then we have systems to just buy what you want, get a concierge. You know, you can do, that's another type of medicine. I don't think we're talking about that. But you should have the same ethical, humanistic relationships with everybody who comes in, rich or poor, the emergency room. The equalizing force is that everybody comes by EMS if they're really sick and they know how to use the system. They may come really sick walking in elsewhere, and you've got to know to find them there when they don't look so interesting in the midst of most of the people who have the same things that might go to urgent care. You've got to be a doctor under tough circumstances because the people have tough circumstances, and that's where it's tough and it's fun.
I wonder how many people in this group had those principles in their application to residency. Probably a high proportion, I would guess. But that's beautifully put, and similar to your paper, I think it appeals to all of our preferred self-image. Stephen, you wanted to say something, and then Stephen.
Without setting up, I think you hit the nail on the head. Every single applicant to medical school has some of that in their soul. I truly believe that to this day. Where do we lose that? And that's getting back to the educational component. How do we build this into our education?
So I think this is really important. I was reflecting on the past few minutes of conversation. I threw the micro-hospital freestanding ED conversation just to get things jazzed up a little bit, and I think it worked. But I was also reflecting on Lou's comments and about we may be this meeting, and that's not a criticism, Harrison, it's a challenge, is till this moment, I had not thought about the Indian Health Services, which is really a great example of partnership that I want to take back to Wisconsin, because I think it's something that we've not had. But I think, and I don't know everyone here in terms of where they're at, but I think we have a selection bias here. Social emergency medicine, a bias of, I mean, every urban center that you can think of is here, but those suburban hospitals, those other hospitals, I practice in many community hospitals over my career. Where is social emergency medicine going to be placed to lose comments? It's emergency medicine. So I had trouble from the beginning about the social emergency medicine construct. What are we talking about? Is it a new specialty, or is it woven into the fabric of what every emergency physician does every single day, no matter where they are? And that their emergency medicine practice at Bellevue is inherently different than my emergency medicine practice and the emergency medicine practice at the Indian Health. But they all have the same basic principles of emergency medicine, and that starts with where the patients are and what they need and all these things that we've been talking about that are so great. But I'm not hearing the voices from these other places that are going to push back on us, and we've talked about this, the thousands and thousands of emergency physicians who, is this going to resonate, or is this going to go, you know what, I got a clock to beat, I got to go, and boy, that's great, but not for me. And so the selection bias is, as this goes forward, perhaps with the section meetings, how are we going to make sure that we see a broad set of voices that complement the great voices that we have here at this meeting today?
I think the ultrasound analogy is a sound one. I've used it many times myself. I think that, you know, if you're not practicing point of care ultrasound in the emergency department, you're probably not optimizing your care of your patient. I think that we can get social emergency medicine to that point where the failure to incorporate social context in your clinical encounter, or in the structure of your department, or in the design of your curriculum for students, or in your policy presentations, the failure to do so does not optimize your care of the patients or your advocacy for patients. And the people who are in the section, the people who consider themselves specialists in emergency medicine, they're the ones who are moving the field forward. They're the people who are doing the ultrasound fellowships. We don't need to do an ultrasound fellowship to incorporate POCUS into our clinical care. We all do it. And you omit it at your peril, probably. And I think that that's sort of what the trajectory of social emergency medicine is. We do have a couple of people here from community practice. We've heard from them a few times, and I am grateful for that. Thanks, Chris. Thanks, Appa. And anybody else who I'm missing who practices outside of the bubble of academic emergency medicine. But I agree, we need to have that, you know, very solid foundation before we move out of this. Appa, you look like you may want to say something, or?
I just want to say that, you know, if there's one thing I've seen, it's, I feel like the people I work with, they're expert dispoers. Everybody's dispoing a patient, and they don't want them to bounce back, and they want to do a dispo that lasts at least for the duration of their shift, if not permanently, you know. And so what I think is what your comment yesterday about, is it Dr. Osborne, right? No, next to you. Sorry. But Dr. Khaldun, your comment yesterday about having a different tier for each level of participating in this, because I think people like to be acknowledged for what they're doing. And I think that acknowledging that as a community physician, you know, you're practicing this level of social emergency medicine, and that means taking into account these determinants, and then having different tiers where people are practicing at is just so practical and wonderful, because what every ER doctor who goes to work is doing every day is we are dispoing patients, and this is integral to dispoing a patient. So I think that it's just very integral to what we're doing, and I think we can find a way where nobody's really opposed to dispoing patients. And that's a really common thing amongst all 36,000 ER physicians that are in ACES.
But as you're an example of, just because you're in a community hospital doesn't limit you to doing just that.
Exactly.
There are many things you can do at any place.
But I did train at Highland, so.
This is a skewed sample. There you go. Damn.
Jay.
So it's interesting because Lou, thank you for saying what you said. It sort of crystallized that we have a whole bunch of challenges. I mean, we have the challenge of trying to incorporate the social determinants of healthcare more widely into our practice. We have the challenge of trying to engage our leaders, whether it be the leaders of a medical school or whether it be the leaders of our hospitals, to get them to provide the services and support what we're trying to do with regard to social emergency medicine. Bellevue may be an institution that is very committed to its community. There are other places that talk commitment but don't act commitment. And so the question is then, how do we engage and align our senior leaders, the C-suite, if you will, to support us, since we're well aware that we need resources in order to do what we think needs to be done with regard to social emergency medicine. And then yet another task is, besides engaging the doctors who are practicing now, how do we build the future by engaging our residents and our medical students and incorporate that into their curriculum? So I think we have multiple challenges. I like very much what Sandy said yesterday in terms of, what are some potentially next steps? And I'm kind of reframing it in my mind with regard to what are the different buckets of challenges that we face and how can we address each one of those?
I didn't in any way mean that Bellevue or any public hospital was in and of itself committed to the values that I have or society should have. But I meant that the physicians who work there believe more strongly in the values of society than the leaders of the hospital or the institution or the university or the city or the state. And so you get people who are fighting to get the job done and move institutions further, just as everyone has suggested, that it's integrated with the Department of Health, it's integrated with the activities outside the community boards, the liaisons, because we wouldn't have had our training program had we not gone well beyond the dean who said never and the city who said never, but the people of the city said yes. And so that's our job as emergency physicians, to do much more than that and to risk hostility of the leaders, because I don't think they're not trained in social emergency medicine or social justice. They have jobs and they don't understand it as well as we who see the patients, whether the nurses or the doctors or the other people who try to do it. So it's not that Bellevue has a better break. Bellevue has a lot of people who just say they're going to act up and they're going to change what's in front of them. And so I think if we don't do that, no matter what we teach people and do, we don't have anything, because none of this is easy. And some of the people to deal with, whoever's worked in any of these things, to deal with victims of torture, to deal with homelessness, it's not that just because Kelly Duran says, please do this, anything happens, because she works 24 hours a day to get the job done the way any complex thing needs to be done. Ed Bernstein describes these issues. None of this came because the institution, Boston City Hospital, didn't carry the weight. Thea James or Peter Moyer or other people have fought hard to get these things done. And they didn't say, when they said no in the institution, they did yes, and they found a way to do it. So if people in the room don't do things like that, they're not getting anywhere. Right, because no one believes that these are the things that we might believe, and we have to demonstrate it, and we have to fight for it. The people above us aren't going to say this is great. They're not trained to say this is great. We have to prove it and do these independent efforts.
And that goes back to and it goes back to what we talked about this morning with regard to, if you will, another bucket, which is leadership. We have to develop our leaders and teach them how to fight.
We have one at the microphone, and then Joni, and then me.
I think building on that and some of the comments people have said, and Eric, I want to kind of go back to what you mentioned about Indian Health Services. Thinking about how physicians can be leaders and thinking about how physician researchers can be leaders. Something that's very important in my work, since I'm a rural researcher, is spending a lot of time in small community rural emergency departments. And I come from an academic background, so I bring a lot of academic, large hospital principles. And when you think about involving small, local, rural community emergency departments, translating, what we do at big centers to smaller centers can be
really powerful, and it can also be a way to get buy-in, and it can be a way to engage communities and community emergency departments and community physicians in social determinants of health screening and thinking about social determinants of health. And so when I think about my work as a rural researcher, I think about it not only as trying to advance science, but also actually as a way to bring those knowledge dissemination, like bring those principles to the community, and then in that way, programmatically, you've actually established something. And I think when we think about doing the research projects that we're doing and thinking about doing the programs that we're doing from academic centers, partnering with other organizations like Indian Health Services or maybe rural health clinics, and non-rural, so other health clinics, urban health clinics, is a really great way to start leveraging some of those contacts, and then actually thinking about implementing them in other circumstances. If academic emergency departments do all this great work and we just keep it inside the academic silo, we're not really doing a whole lot, necessarily for the communities that we're serving. And so thinking about engaging smaller local centers in our work, I think is very important programmatically and very important to get back to the community. And also can serve as sort of like a small implementation project. Working with smaller, organizations, it's actually much easier sometimes to get things done and implemented. And if we start doing a lot of social determinants of health screening at big academic centers, and we're not sort of trickling it down to other places, I think people are going to say this isn't feasible, and we're going to experience some pushback. So.
Let's see, Joni.
Yeah, I just wanted to say, I think one of the great things about the Affordable Care Act is it really, in case people don't know, forced at least nonprofit hospitals, if they weren't before, they now have to do a community health needs assessment and an implementation plan, and they have community benefit dollars that they have to spend. So in one hospital that shall remain nameless, the leadership, when I first started working there, I went to them, with all my rah-rah social emergency medicine hat on, and they told me they had 3 community health fairs, and I could certainly set up my Ask the Doc table and do it. And then the ACA passes, and I go back to them, and they're looking at me, can you be in our committee? We want to get this grant. How can we? It was also in Maryland, which has a very unique health policy situation there. But anyway, they were concerned about keeping people out of the hospital because that's the policy landscape in Maryland. But again, using those levers, I know some of us in the room have been able to, when they feel like they can't use their dollars, they're looking to us. Like, what's that project again? Okay, fine, we'll fund you. Here's the money. And then they check the box, which is their box that they have to check. So recognize that there are some things that hospitals, at least nonprofit hospitals, which most are, have to do to maintain their status. So use that to your advantage.
And to piggyback on that, same with Medicaid health plans. Yep. There's they have to do a lot of stuff, and they often have strategic reserves that they have to give back out to the hospitals they contract with. So that's a lot of opportunity.
I've got Medicaid health plans now agreeing to pay community health workers' salaries. All right.
That's who's paying my healthcare navigator salaries.
See, exactly. So there are things.
Yeah, and also thank you for, to the last couple of commentators for bringing the conversation back. We have probably 10 minutes left, and I want to make sure that we don't give short shrift to this idea of what we can do facing out from the emergency department. The big P, little p policy alternatives, I think, are still opaque to many of us. Exactly how do you do this, and what needs to be done, and who do you call to get involved in the the rule writing, and we lost Zach, unfortunately, but who do you call to get involved in the implementation plan for a new city policy? How do you do that? How do you actuate that goal? I think is something that I want to spend a little bit of time discussing. We have 2 people at the microphone, and then I want to recognize them, and then I want to use the last few minutes to try to give us all some concrete. I think we've talked about, yesterday we talked about some concrete things that emergency departments can do to work towards social emergency medicine. Today, I want to at least spend some of our time, and we have already, thank you, spend some of our time outward facing, but I want to use our last 5 or so minutes for that. And then Art, and then Austin, and then I'm going to turn the conversation back to that.
So maybe one of your last comments there about big P, little p is a segue into some thoughts I had to share with the group, which deals with regulation. And regulators are always playing catch up with what's going on in culture and society. And I've been thinking as I've been sitting here with you over the last couple of days of just how a role that I have and the fortunate opportunity for me to sit here with you and look at the seed that's being planted by this group and the thoughts that are going on. So as I leave here, what role do I have to offer and play in this as a regulator? So I'm thinking about, for instance, my role at the state medical boards and how could this come into play at the state medical boards. So what happens there is you as members of this concept that you're evolving need to talk to somebody that's on the state medical board, and resolutions come to state medical boards of what needs to be done. So the example I'm thinking of that happened this past year has to do with the PDMPs in various states and how physicians perceive that. Some of them don't want to do it because it takes up time, but the state medical board, House of Delegates it's called, took that on themselves. There's a big work group looking at this to try and come up with what's the best policy around this to make this happen. The other thing that came up was licensure with EMS workers came from the state of Montana. So we were asked to come up with some concepts around what's going on there with the licensing of these different types of individuals. So when you're talking about what you want to have happen in your emergency rooms, we can be helpful to you in trying to draft some policy that comes out. I'm going to leave here and I'm going to Washington to meet on all day Monday with a group called the Consortium of Physician Accountability. This is a group of all the leadership of all the major alphabet soup organizations that exist. And one of the things that's going to come up are emerging health trends. What's going to get mentioned in emergency health trends is what you've been talking about here the last 2 days, that I will have the opportunity to share with everybody that's there in that room with some ideas that I can tell them that they need to start thinking about as they look at things. The other thing, I've been attending the e-health, telehealth meetings periodically that go on and looking and talking to those individuals. There's a group of people that are spending all their time trying to be creative in telemedicine, and the majority of them are businessmen trying to figure out how to make money on this, how to take and run a stroke program for hospitals that don't have enough physicians. They're looking at it purely from the objective of how they're going to make money. Somebody like me needs to stand there with them and say, what about the social responsibilities and how do you change what it is that you're thinking about doing to make the quality better in that emergency room, not just to make money for your own business. So I think that, you know, the opportunity to be here, and I think in the future as you evolve this, you need to get some people that are involved in these type of things that can really be advocates for you to make things happen in the direction you're trying to take them. So thank you for allowing me to come, and I hope that I've added a little bit to the discussion of your meeting.
So there's a policy idea. Anybody who wants to try to effectuate some area of social emergency medicine that can be achieved through the regulatory arm of the self-regulatory arm of medicine, maybe through the burnout pathway or something like that, they know how to get in touch with Art. Austin?
Kind of on that note, I'm wondering if there's a level at which we should focus our advocacy and focus our kind of our policy level. I think we're all inclined to do this at the institutional level because that's kind of easiest for us. We know our institutions, we know our local partners, but whether we should be focusing more on the city, county level, state level with our national partners, our regulatory bodies, CMS. And it's, I mean, obviously the answer is all of these things because they all interact. The ACA, it sounds like, enabled, local institutions to have more money to invest in the community needs. But I wonder if, as a group, is there a starting point, a starting level that makes sense for us to kind of target with our advocacy and our research as well?
Well, I think that Joni hit it. I think the Affordable Care Act sets up the relationship of the hospital and its community needs assessments and its relationship to public health and to the community, I think that's a natural place for many of us to engage with hospital systems like it's never been before. I think this is new and exciting, relatively speaking, 10 years ago, 15 years ago, when it was just PR and not really substantive. So I think that's pretty low-hanging fruit relative to complex things on a state or federal level. But I think Joni's right on top of it. That's where we can really make a difference and engage our hospital leaders in a way. They're talking about population health and public health. They never talked about these things before. So I think this is a very good opportunity in our relative communities.
Ewan.
I think this room has, again, as I've said before, so much expertise, so much enthusiasm, so much dedication. And what we have to really be careful is that with the formation of this group, we have strength to do things that we could not do, but also to really remember the people who are not here. And social emergency medicine, I believe, is part of the foundation of being a physician, okay, so social medicine. And that shouldn't be a specialty, okay, that is medicine. And if we create specific fora for just academic researchers, or if we neglect community physicians and community EDs because they're all for profit, or if we neglect to think about different groups and use our strengths to partner in different ways. So academic institutions working with inner city, perhaps a network of community physicians, rural physicians. I mean, being a good doc, being a really good doc is good social emergency medicine. It is good medicine. And I think that if we elevate ourselves or forget that aspect, we'll alienate a lot of people. And it's neglecting an important role that we have, because first and foremost, I think we all are practicing physicians. And so I just like to make a plug for, while we develop an exciting research agenda and programs, that we don't leave out or forget the really good clinical work people are doing, programmatic work people are doing, even at an institutional level, even at, one ED. I think a lot of that is important. And perhaps what we have is a strength to be able to connect these different dots and elevate a one ED research program to a collaboration and network, and be able to get funding for these different things. But I'd like to caution ourselves about getting too excited about the academics and the research and the ideas, and also ground ourselves in the practice and the day-to-day and the immediacy of, I think, a lot of the values and work that we really value.
I want to build on what both you and Dr. Goldfrank said, and then also something that Dr. Khaldun had said yesterday. I am in firm agreement that it is medicine, and but that fight that Dr. Goldfrank was talking about with our institutions, or with, that is something that does take a lot of persistence and fortitude and empowerment, and I think in social emergency medicine, we're talking about empowering our patients, but as Dr. Khaldun said yesterday, all of us are subjected to these social determinants of health. This is part of who we are and how we live and where we work. And as we're thinking about training, I also think I would love us to also collaborate effectively with the diversity and inclusion group within ASAP, because I think it's a natural collaboration, and I think it's an incredibly important one, so that we really foster a diversity of talent and a diversity of perspectives, and really empower a number of people who, in the current system that is heavily weighted towards the business side of medicine, how do we empower individuals to actually take the responsibility that is our natural and responsibility as physicians. But I do think, thinking along the terms of empowerment, is one way to, again, include all of the community physicians, include everyone who's out there practicing.
We're at time, but we have somebody at the mic who hasn't been heard from yet, so.
Yeah, my name is Carl Berdahl. I'm from the National CSP at UCLA. And I just kind of wanted to echo some of the dialogue that's happening at the end here, but in perhaps a more structured manner where I feel like this could go, which is that I think that having a standardized social needs assessment, I don't want to call it a screener, that we can build this tool that will enable us to, perhaps even mandate that this is done for every patient at like the 6th vital sign, somewhere in triage, so we have somebody up front doing this. And so I think that we bring this to the community EDs, and we use their strength, because I think that, community physicians actually want to disposition patients well. They want to do their best for the patients. And I think that, by having a structured tool that we can kind of mandate to be disseminated, then we have the information at our fingertips to know what the problems are. And that I think their strength lies in having these tools available to the community physicians who are going to advocate at their institutions once they see the direction this is going. And so I think particularly with the social EM section of ACEP, we have the opportunity to reach out to the ACEP membership and get those community physicians to join this movement, after we've gotten it rolling. I don't know if that makes sense, but.
It's a very nice, oh, wait.
So I really like the idea that you just mentioned in terms of creating a screen. If I can just put I really have two comments. One is about the screen and one is about the sort of format of what you're all talking about again. The screen, if I could just offer a word of caution and a solution, and that is we screen for just about everything these days. And I think, I don't know about you, but I get this printout of stuff. And it's really difficult to screen for something when we don't have something to do with that information. So we're talking about, for example, we're talking about screening for universal screening for suicide ideation. Makes great sense, but if you don't have a way to hand that patient off or a resource, then you get angry, you get frustrated, you don't want to do it because there's nothing you can do with the information, and now you're even worse off than you were the day before when you didn't know it.
Yeah.
So when I think if you're going to do a screen, you begin to think about something that you can offer that every emergency doc that screens for that is going to say, okay, you didn't have a tetanus shot, we'll give you a tetanus shot. That's sort of, if I screen somebody that doesn't have a tetanus shot, I know what to do, right? But if I screen somebody that's homeless and I'm in, another city, I don't know what to do. So that's one. The other thing is when I came in the conversation, I apologize for having to step out. You guys were talking about sort of this splintering and where should the focus be? And it really sounds to me a lot like global health, and maybe Steve can comment on this. But in global health, you have this issue of having to provide the need to the people who are right there in front of you in a third world country. And then you also have the need for creating an infrastructure. And then you have the need for creating the advocacy and the policy that allows that infrastructure to go, but at the same time you have that need. So I think what you're talking about is you have the need and you have people who are doing amazingly good work in the field right now with the patients making things better. But you also need to develop these other layers, and you need to be able to push all of those things out at the same time, very much like I think what you get when you have a global health type discussion is you've got like these three groups of people and they're like, what are you doing? I'm doing the real thing.
Thank you. We are at time, but again, we have two more voices that I don't think we've heard from. So
just a quick point. Dave Silvestri, one of the Yale Commission scholars. Thank you for having us here. I've enjoyed hearing everyone's perspective, learning from you all. One thing I think that hasn't been said, most of us probably have been thinking about it at least at some level, that I just want to kind of get on the record here before we sort of wrap things up. We've talked about a research agenda, we've talked about a policy agenda, we've talked about an educational agenda. And a lot of that has focused on us as emergency physicians and perhaps even more broadly at other cadres of physicians, other specialties. I do think that it's important for us to realize that there are other important and very relevant health practitioner groups and physician assistants and advanced practice nurses who work alongside us, but don't necessarily have much like our training, don't have specific focuses on these social determinants of health, and I think could benefit as well from us joining with their professional organizations to try to advance these sort of agendas within their organizations as well, so that we're all doing this alongside. Getting back to the bias point that we sort of talked about a little bit yesterday, I think one of the reasons it's so hard is that even despite our best efforts, a lot of our non-physician colleagues in the emergency department will have other biases that we cannot begin to undo unless we're working with their organizations as well. And that's, I just wanted to get that out there. Thank you.
Todd, you get the last word.
Hi guys, Todd, fellow at UCLA. Thanks for having me here. But one of the things I wanted to, we're kind of circling or orbiting in a lot of these talks is we're talking about making the ED an agent for the community and kind of this attitude of community advocacy through the ED. And the things that give the Dr. Corbin's, the Dr. James's, their gravitas when they're talking is kind of that grounding in the community through what they've done in the ED and using their position in the ED to really connect with the community and bring something that's that upstream is really just being an advocate and finding a way to grassroots organize through mentorship and things like that, and having a grassroots advocacy platform that we all have from our ED to kind of bridge that big P, little p. You know, we're working in the ED and we're trying to get to a policy level that Dr. Barsati's at. You think about where that comes from, a lot of times it comes from us engaging with that community, whether it's in Vermont, where you have a very different landscape in terms of what people are interested in. When we're talking about, you know, my backyard is the East LA immigration issues, and your backyard is rural gun issues. And we have ways we can engage a national platform of ED physicians and be able to tailor things to what their community actually needs and wants. And starting with that, I think we have a huge strength here in that all these people have really found a way to engage with their community and have an intense expertise in community engagement that we, you know, as much as we have good researchers and a lot of other important groups, we have people who can advocate and people who can speak from the pulpit of the emergency department, and trying to figure out the framework or ways that you can franchise things like what Dennis has done or, you know, Dr. James has done would go a long way in terms of, if I think about the Skid Row community ED that I moonlight in, they love a lot of these ideas. They love a lot of these, you know, kind of frameworks. They aren't going to do research. They aren't going to be interested in a screener or asking more questions. But first, if we go with that, hey, this is some frameworks. These are some things that it might be easily franchisable to your ED in a quick and easy way that can add things that they know are important to their patients' lives, go a long way. Then come in with screening and some of these more research questions later.
Thank you. Okay. I think we'll close the entry of more research questions. We're going to take a 15-minute break because everybody needs to stretch their legs and do jumping jacks. The reason we went over was that we have a little bit of flexibility on the other end. So we're going to close the submission of new research questions at 1:45. So time to get those to Lauren and give her time to get them up on the website before we vote at 11.